sorry to rush everyone, but I've been told that we need to finish on time so the satellite symposium can start. And I've also been told that people should exit this way so you don't disrupt the satellite symposium. First of all, thank you for being here. I was worried at the end of the day everybody would be drinking by now, so thank you for being here. My name is Michael Niederman, and I'm going to discuss with you the possibility of a simplified algorithm for all pneumonia, meaning that we could treat all patients with one algorithm and maybe simplify how we currently do things. So I've listed my disclosures here, and I think that the background for how I would like to present this is that we now have a potentially very complicated situation with all the different alphabet soup we have for pneumonia. We have community-acquired pneumonia, healthcare-associated pneumonia, ventilator and hospital-acquired pneumonia, and I think things became more complicated when we introduced the concept years ago of healthcare-associated pneumonia, conceptualizing it as in between community and nosocomial pneumonia, and on a spectrum of increasing risk factors for multi-drug resistant pathogens and increasing morbidity and mortality. And so potentially, at that time, we said maybe we should be treating all of these pneumonias a little bit differently, and we had algorithms that were different for each of them. And the frequency of different pneumonias was cataloged in a study around that time. If you took all pneumonias, about 50% were community-acquired pneumonia, hospital-acquired pneumonia was about 20%, ventilator-associated pneumonia less common at about 10%, but healthcare-associated pneumonia was relatively common at about 20%. And as you may remember, in 2005, when we wrote guidelines for nosocomial pneumonia, we included healthcare-associated pneumonia within nosocomial pneumonia guidelines. The latest ATS-IDSA guidelines rejected that, did not include healthcare-associated pneumonia, and suggested that healthcare-associated pneumonia is now rightfully a form of community-acquired pneumonia. And I would like to try to avoid that debate and discussion and simply talk about all pneumonias potentially being managed in one way. So how should we think about treating pneumonia? Should it be by the site of pneumonia origin? Well, the problem with that is there are patients with community-acquired pneumonia, HCAP, HAP, and VAP, who are at risk for MDR pathogens, and patients in those populations that aren't at risk. And it's probably, in my mind, it's the risk factors for the MDR pathogens that's common to all forms of pneumonia, and the site of origin probably doesn't matter very much. Severity of illness, on the other hand, is an important factor, but maybe not in and of itself enough to determine by itself the way we treat pneumonia. So in other words, not all ICU patients per se have to be treated alone in the same way, because some are and some aren't at risk for different pathogens. And this study from several years ago asked the question whether severity of illness alone predicts bacteriology in ICU-acquired pneumonia. And you can see in 350 patients with ICU-acquired pneumonia, some ventilated, some non-ventilated, severity of illness is reflected by Apache score, a SAP score, or even the clinical pulmonary infection score, had no correlation with the presence of MDR pathogens. So severity alone would not be a good way to predict which pathogens you want to treat with pneumonia. So should we look at mortality risk? Different patient populations have a different risk for mortality, but that alone I don't think defines therapy. And I think a more logical and reasonable way, a more unifying concept, is to think about all patients and their relative risk for MDR pathogens. That has some bearing on severity, but ultimately I think that the risk factors for MDR pathogens are most important in defining how we want to treat pneumonia. So I guess the question is, are you a lumper or a splitter? Do you look at that pile of logs and see a whole different types of logs? There's CAP logs, HCAP, HAP, and VAP logs, or do you put them all together in one big pile like is there and consider them all pneumonia? And I think I would prefer to be a lumper, not a splitter, and I would like to think of all of our patients with pneumonia generally being managed in one thought process, one mindset. So is a unified approach really possible? Again, currently each form of pneumonia has its own algorithmic approach. We have guidelines for each form of pneumonia, and that's a tremendous complexity. Is it really necessary, or should we try to focus on the similarities and not the differences of the pneumonia types? And I think, as you'll see from a study that was just published this month, I think it's possible to do this unified approach, but let me build to that data. First of all, the risk factors for MDR pathogens apply to all pneumonia patients. These patients can have pneumonia arising in the community, in the hospital. What you want to know is there a history of prolonged hospitalization, serious medical comorbidities, prior antibiotic exposure, are they coming from a convalescent home, have they recently been in the hospital, do they get dialysis, do they have other forms of immunosuppression. These are the factors that in my mind determine how I want to treat the patient. It doesn't matter whether they acquired that pneumonia in the community, in a healthcare related facility, or in a hospital. These are the factors that matter the most. The problem also with our current approach is that the standard therapy for community-acquired pneumonia may not be enough for some ICU patients, and it may be too much for others. This was a study looking at community-acquired pneumonia. 2 to 30% of all patients with community-acquired pneumonia are known to have gram-negative pathogens. In the review that's cited above, about 20% in all, when you take all the studies together, have gram-negative pneumonia. So what does that mean? Do I treat every CAP patient for gram-negative pneumonia? The study that's shown here looked at about 250 patients with CAP in the ICU, and in only 16% was that third-generation cephalosporin not adequate. But on the other hand, if you look at whether it was overly broad, in general, they concluded that it was appropriate therapy 18% of the time. It was inappropriate therapy 16% of the time. But in all the other patients, using a third-generation cephalosporin was too broad. So we have 3 populations of CAP patients alone, some where we're not treating them broad enough, some we're treating them too broad, and some we're getting just right. And so we need to have a way of thinking about this that's different from what we're currently doing. And similarly, in a study of HCAP in the ICU, our therapy also may be too broad. This was a study of over 700 pneumonia patients in 34 different ICUs in Spain. 45% of the HCAP patients got CAP therapy, in other words, a narrow spectrum therapy, and 90% would have had appropriate therapy with simply a CAP regimen. So only about half the patients got a narrow spectrum regimen, when 90% would have been fine getting a narrow spectrum regimen. So these patients were clearly being treated too broadly. We need to find a way to avoid the under and over treatment that currently follows from our existing algorithms. A study done in Japan tried to predict the risk factors for MDR pathogens, identified that the risk factors for resistance in CAP and HCAP were generally the same. They include the same things we've seen before: prior admission, immune suppression, recent antibiotics, and feeding tubes increased risk factors. But they established the concept that the more risk factors that are present, the greater the likelihood of resistant pathogens. And what's illustrated here in each bar, the dark represents patients with MDR pathogens. You can see as the number of risk factors rise, the percentage of the pneumonias that are due to MDR pathogens is greater. So this, again, begins to make, to me, some sense that looking at the risk factors is the best way to predict the MDR pathogens. Dr. Torres's group has done a slightly different version of this concept, referring to the pest concept that refers to Pseudomonas, ESBL-producing Enterobacteriaceae, and MRSA. Those 3 organisms represent the pest pathogens, and in a study of 1,500 patients with community-acquired pneumonia, 6% had the pest pathogens. And illustrated here, and I don't have time to go into it, is a scoring system to identify which patients are most likely to have the pest pathogens. And you can see as that score goes up, again, the risk of these MDR pathogens rises. And so conceptually, I think we can buy into the idea that these risk factors, which are similar in most studies, are important. And the more of these risk factors a patient has, the greater the likelihood of MDR pathogens, independent of whether it's CAP, HCAP, or nosocomial pneumonia. So in a review article that we just did a few months ago for intensive care medicine, we identified the risk factors for the pests and MDR pathogens, and they fall into 3 categories. There's therapy-related risk factors, there's patient-related risk factors, and then there's antibiotic selection pressure. And all of these are the factors that you need to consider in every patient to define the potential for them having MDR pathogens. Functional status is another important risk factor to consider. There is a measure called the Barthel's Index, which includes a variety of different variables listed here. And the lower the Barthel's index, the more impaired functionally patients are. And what you can see here is mortality rate in the setting of pneumonia, in this case, gram-negative pneumonia in the setting of community-acquired pneumonia is tremendously higher in patients with a low Barthel's index. The frequency of gram-negatives and the mortality rate is much higher with a low Barthel's index than with a higher Barthel's index, and this is another important factor. So I'll skip over this for the time being and go. Based on all this thinking several years ago, we tried to, as a first step, develop an algorithm for treating HCAP. And HCAP was at that point a model for all pneumonias because we understood with HCAP that it was a very heterogeneous group and that, as I showed, many patients are getting overtreated, some are getting undertreated, and we needed to find a way to identify which patients should be treated in which specific way. So we developed an algorithm, which I'll show you in a second, that we used in 445 patients, 320 which had healthcare-associated pneumonia. And with this algorithm, and at the time the recommendation for HCAP would have been to give all of these patients multi-drug broad-spectrum therapy, we followed the algorithm and only about 50% ended up receiving broad-spectrum therapy, and yet over 90% that was appropriate antibiotic therapy. 27% of high-risk patients defined by the algorithm did have MDR pathogens, and the mortality rate was related to the number of risk factors and to the failure of initial therapy. And you can see the algorithm is shown here. We identify patients who have healthcare-associated pneumonia. That's because they reside in a nursing home, they have been hospitalized for 2 or more days, they're getting dialysis or IV antibiotics, and in the 320 or so patients with healthcare-associated pneumonia, shown here, we divided them on the basis of severity of illness, and then we looked at 4 specific risk factors: antibiotic therapy in the last 180 days, poor functional status defined by a low Barthel's index, hospitalization for more than 2 days in the last 90 days, and immunosuppression. And then we further looked, did they have severe pneumonia, yes or no? So if they had non-severe pneumonia, and they had at most one of those MDR risk factors, they were defined as low risk. And similarly, if they had severe pneumonia and none of those MDR risk factors, they were also defined as low risk. And about half the population were low risk. These individuals received CAP therapy. The higher risk population, the non-severe pneumonia who had more than one risk factor, or the severe pneumonia with one risk factor, these individuals ended up getting broader spectrum therapy directed at multi-drug resistant pathogens. But again, most of these patients got broad spectrum therapy, or only half of these patients got broad spectrum therapy, most of them got appropriate therapy. Mortality, as you can see, was related to the number of risk factors for MDR pathogens. But again, this established for me the concept that we could develop an algorithm that could divide patients up, and that we could use that algorithm to better identify who needed broad spectrum therapy and who didn't. And so we just published this paper that was published in CID this month. It was online, though, for a few months. And this was a therapeutic algorithm for all patients with pneumonia. It was a 3-year prospective multi-center cohort study done in Japan, developing an algorithm and being followed for all patients. And the population that we looked at is shown here. We had 650 patients with HCAP, which is defined as shown. We had 238 patients with healthcare-associated pneumonia, 140 with hospital-acquired pneumonia, and 55 with ventilator-associated pneumonia. So the majority had CAP and HCAP, but we included in this algorithm patients with nosocomial pneumonia. And the algorithm is shown more specifically here. We define whether pneumonia is present. Again, we look at severity of illness, and we look at the risk factors in this algorithm: recent antibiotic therapy, poor functional status, recent hospitalization, being in the hospital for at least 5 days, hemodialysis and immune suppression. And again, if there was non-severe illness or severe illness with no risk factors, non-severe illness with one risk factor, groups 1 and 3 generally got treated like community-acquired pneumonia. Group 1 got treated for CAP pathogens with either a quinolone or a beta-lactam macrolide. Group 3, who were severely ill, got, again, a beta-lactam with a macrolide or quinolone. These groups 2 and 4, were more at risk for MDR pathogens. Group 2 was not severely ill, and the recommendation there was an anti-pseudomonal beta-lactam plus a second anti-pseudomonal drug like an aminoglycoside or quinolone. And depending on your clinical assessment, you decided whether you wanted to cover MRSA in that population. And for the last group, the sickest group with multiple risk factors, here again, the same therapy of an anti-pseudomonal beta-lactam, a anti-pseudomonal quinolone or aminoglycoside, plus again, consideration of vancomycin or linezolid. So when we applied this algorithm prospectively, 82% of the time, patients were treated according to the algorithm. When that algorithm was followed in that 82% of patients, only a little over 4% got inappropriate antibiotic therapy. MDR pathogens were present in 50% of the patients with VAP, 27% with HAP, only about 11% with HCAP, and only 5% with CAP, but they were not zero in any group. When patients had at least 2 MDR risk factors, compared to 1 MDR risk factors, then the risk of MDR pathogens was 26% versus 5%. And the mortality rates, as you might expect, were higher for the nosocomial pneumonia patients and a lower mortality rate with fewer risk factors. And MDR risks in appropriate therapy were the risk factors for mortality, but the site of pneumonia acquisition, the type of pneumonia, had no bearing whatsoever on the mortality, because, again, these patients were frequently getting appropriate antibiotic therapy. What happened when the algorithm wasn't followed? Remember, 82% got treatment according to the algorithm, 17.5%, so nearly 200 patients, the doctors used a different approach. They chose not to follow the algorithm. And although they got about the same, actually a slightly lower rate of inappropriate therapy, the rest of the management, I think, was suspect. 74 patients in this population got a narrower spectrum therapy than the algorithm recommended, and here 10% got inappropriate therapy. But I think this is where the real problem lies. 117 patients got broader spectrum therapy than recommended, and although there was 0 inappropriate therapy, again, 117 out of 190 patients were getting broader spectrum therapy than was absolutely necessary. So this, to me, is the downside of not having a more careful algorithm, is that you end up getting it right, but at the expense of tremendous overuse of antibiotic. Initial treatment failure rates were higher than the rates of inappropriate therapy. So in other words, the patients were sometimes doing poorly, independent of whether they got the right antibiotic. If you look more carefully at the treatments that they got in community-acquired pneumonia, remembering groups 1 and 3 are the low risk, the frequency with which broad-spectrum therapy was used was about under 5%. In HCAP, it was about 50% got broad-spectrum therapy. And then in nosocomial pneumonia, narrow-spectrum therapy was relatively infrequently used. There was a good relationship between functional status and the pneumonia type that was present. Poor functional status overall was in about 30% of patients, relatively uncommon in CAP, and almost ubiquitous in nosocomial pneumonia. But again, about 1/3 of the patients with healthcare-associated pneumonia had poor functional status. And I think this is probably, to me, the biggest argument for why we should have a unified algorithm, at least in terms of predicting mortality. In the univariate analysis, the type of pneumonia mattered in terms of whether it was an impact on mortality. But in the multivariate analysis, the type of pneumonia had absolutely no relevance whatsoever on outcome. Other factors were much more important. So these data say to me it just doesn't matter whether it's CAP, HCAP, or VAP. To determine mortality, you just follow an algorithm, get therapy according to that algorithm correctly, and it's very unlikely that mortality will be adversely impacted. So in conclusion, currently having separate algorithms for CAP and HAP could add complexity that's probably not needed right now to manage pneumonia. HCAP has always been a unique illness, but it needs to be evaluated in relation to risk factors for MDR pathogens. And using this algorithm, which I'm calling simplified, but obviously it's not that simple. You have to look at it very carefully. But applying this to all pneumonia patients leads to a high rate of appropriate therapy. It avoids undertreating some patients. It avoids the overuse of antibiotics in many people. Again, the majority of people who didn't follow this algorithm ended up getting much broader spectrum therapy than was necessary. And I would say this is a start. This is not necessarily the only or the best algorithm. And I think it needs to be tested further. It needs to be validated. But to me, this is at least the beginning of, I hope, a different thought process, which is to start thinking about pneumonia as a disease and not as 3 or 4 different diseases, and start to think about the commonality in all patients and use that approach to organize therapy that applies to all patients. Thank you.